my name is John Stites. I'm a urologist at Georgia Urology, and today I'm going to be talking about enlarged prostate. We're talking about it in a general context, and also talk about some treatment strategies that we have, and how we can kind of approach this, especially for patients who are maybe new to this disorder and new to this kind of problem. So to get started, we're going to talk about what is the prostate, what does it do, what is the normal purpose of it, and also what happens whenever it becomes enlarged. So whenever we're dealing with benign enlargement of the prostate, or BPH, benign prostatic hyperplasia, we talk about how is this diagnosed? How do we confirm you actually have this problem? How do we know we have it? And is there could this be something else? And if we do have it, what do we do about it? So we'll start just here from the beginning about the prostate itself. So the prostate is something that all men are born with. It's a secretory gland that's about the size of a walnut, as it mentions here, and it sits below the base of the bladder. It develops and becomes more functional during puberty. Its main purpose is to produce seminal fluid. So this is the liquid vessel that transports sperm and allows us to reproduce. It surrounds the urethra. What you see here is an image of it's sort of a coronal cross section. But if you can imagine in 3 dimensions, it has a donut-like shape. So it surrounds it all the way around circumferentially. And it basically secretes from within that channel, and basically all that your urine flows outward passes through this channel naturally every time. Okay. Now, whenever we have problems with the prostate, this can manifest in different ways. You can first off, just starting from the left here, you can develop a problem called prostatitis, which just means inflammation of the prostate. This can happen really in a range of ages. I see patients as young as in their late teens, all the way and onward can develop this. This can happen occasionally. I tell patients that just through bad luck, it may happen once or twice over the course of your life for no other good reason. It can be related to bacterial infections. It can be related to other chemical causes, medications, other conditions, but it can be related to an enlarged prostate. Okay, which is the next one over. Now, enlarged prostate means benign overgrowth of normal tissue. All right, this is not the same thing as cancer, which is a malignant change, which has the potential to proliferate and metastasize and that sort of thing in some cases. Benign enlargement just means that we have an overabundance of normal tissue. Okay, so the reason that this happens is because of testosterone in our bloodstream. All right, so when we're in puberty, it starts to your testosterone levels start to increase. And a natural function of testosterone in the body is to stimulate cells within the prostate to remain active. This is just basically a normal part of puberty and a normal part of reproduction. And of course, we have naturally a sort of an ambient level of testosterone in our bloodstream at all times. And so that sort of continuous exposure has a cumulative effect of making the prostate grow. Okay, and this is a natural process to a degree. Everybody's prostate gets enlarged, but about up to 2/3 of men develop problems because of overgrowth affecting their urination. Okay, and it's a very, very common problem. So as you can see here, is the older we get, the bigger it gets, the more likely we are to eventually develop a problem with it as the decades go on. And as you can see from this study, which actually is a very old but still very relevant study from the 80s, that the older we get, there's a very linear rise in the percentage of men that have a problem with this, and it just has to do with this continuous growth over time. Okay, so again, this is just to sort of illustrate this term. It's non-cancerous enlargement. All right. It's an extremely common picture, as is prostate cancer. Whenever patients come in for an enlarged prostate, we're always looking for cancer at the same time, and that's just sort of a routine. It doesn't mean, though, that whenever you have these symptoms that you have prostate cancer. So when a urologist asks about your prostate cancer screening history, it's just a matter of putting it into context, because both of these orders are so common, they're very prevalent. So again, it doesn't. These symptoms don't are not an indication or predictor of prostate cancer. And both of the risk of both issues rises over time. So again, we're looking at those in concert. Okay. The and as we mentioned here, it starts to grow. It starts to pinch on the urinary tract and cause obstruction, and that's really the mechanism by which it causes problems. Is squeezing in and narrowing the channel through which the bladder can void. All right. So as it does so, the bladder will start to have to fight harder and harder, and this leads to some gradual changes. All right. It has to, actually start to thicken the wall, as you can see here over in the right-sided image here. The bladder wall will actually start to thicken, just like another muscle in your body would. Such as if you're, exercising and or in the gym or something, your muscles eventually start to become stronger and thicker. Same thing with the bladder. All right. So very often when we're looking at imaging in men who've had an enlarged prostate for long enough, you'll see a much thicker bladder than you would in a non-obstructed bladder. All right. And really the determinant of symptoms is not just necessarily the size of the prostate. It's a matter of how much it blocks the flow. So if we were to scan a random patient, we see that he has an enlarged prostate. There's no way to really tell from that alone whether that patient has symptoms or bother from that. For example, I had a patient once who was an older gentleman, and his prostate was like almost a kilogram. Okay, and it's the biggest one I've ever seen. But that man had no problems with it because he didn't really have a significant degree of obstruction on the inner channel. Most of his growth was outside of that. So that means that the size doesn't necessarily dictate or indicate directly how much of a problem it is. And so smaller prostates can have a significant amount of bothersome obstruction. And that means that an outside look is not the only way to tell. And we'll get to a little bit more about this diagnosing later here in just a moment. What are the symptoms of an enlarged prostate? Well, usually when men come in general, it's often a mix of two kinds of symptoms. They'll have issues getting the urine out, but also storing the urine. All right. So, for example, a man will come in because he's having a lot of irritation. He's having to go. He can't store for very long. He has to get up 2 or 3 times a night. He has to go frequently during the day, and so the bladder will spasm and cause these issues. But at the same time, he may also experience, paradoxically, difficulty getting that urine out that his bladder is telling him to void. And this makes sense when you know the pathology of it. See, whenever the slow stream makes sense because if it's a more narrow channel, there's a tighter grip and it's harder for that urine to move along. But the spasm happens because of a reaction of the bladder. All right. Whenever the bladder's having to fight harder than it really can, apply extra pressure to empty, it will start to have these spontaneous urges. Think of these as spasms, and these are really a warning signal from the bladder that it's running in red. It's fighting harder than it's really capable of, and it's really being strained. Okay, and this is the most common general scenario for men who come in with under controlled prostate enlargement. Okay. Now, most men who come in with these same problems often have already experienced significant effects to their quality of life, and that's often what drives men to come in. The first and foremost is men who are having interruption with their sleep. If you start losing sleep, it really starts to be disruptive to almost every other element of your life. This lots of times they'll have daytime symptoms too. They really don't have much time in between voids. So, knowing where a bathroom is, keeping one nearby is very common because lots of time when these urges come on, they don't have a lot of delay. Their bladder's telling you, no, you're going to pee right now. And the patient's not making this decision. The bladder's making this decision for them. All right. And that's itself pretty disruptive. If it's affecting leisure activities, time with family, of course, this difficulties meaning that you're having to take longer. You start using stalls. You start adjusting your life in general. Okay, and whenever your urination's writing the story of your life, that's not any kind of quality of life for a lot of men. So This is what often drives men to seek treatment, because this is telling them that they really can't take much more of this. If it's not treated, not only can those symptoms, basically continue until we get the problem under control, it can lead to permanent damage. All right. So if you, from a functional point of view, when this obstruction is going on long enough, these this the strain on the bladder that I mentioned can lead to permanent damage. All right. Now these images shows just sort of successive damage to a bladder and what that can appear like whenever we look inside with the camera. On the left side, we have pretty healthy, normal looking mucosa, nice and smooth. All right, those are normal little blood vessels and a nice smooth contour. And that's how it should look. Now, as it gradually worsens, you'll see a greater amount of these sort of bands here. These bands are actually not muscle tissue of say strain. It's actually fibrosis. This is scar tissue. Okay, and in between these are areas where it's almost both inflating and pop-off valves to the point where it starts forming pockets or diverticuli. And this is what a very badly damaged very badly damaged bladder starts to look like over time if it's obstructed and essentially working harder than it's capable of. All right. Now, whenever this happens, if you see a bladder like this, these not only does it become weaker, it leads to other problems. But a lot of this, the first thing that often happens that I tell patients is, first thing that may happen is some of these symptoms may not go away even with treatment. And we'll get into timing of treatment and how to when to make that decision here in a moment. But this can escalate further and further. If whenever we start to see this permanent damage, we also start to see difficulty emptying. Okay, so if the bladder starts to weaken, it can no longer empty all the way, and that's when other new medical problems actually start to arise, secondary medical problems, and that's when it can get even more serious. That undraining urine leads to infections. It's stagnant urine. It's not emptying. Bacteria have a chance to set in, fester, and cause recurrent UTIs. Very common scenario. Blood in the urine can come from basically irritation, engorgement of the prostate gland. Bladder stones can form from that stagnated sediment in the bladder, which themselves require surgery whenever we find those. Even urinary retention, dependence on a catheter. Okay, and if left long enough, it can lead to permanent retention or even renal failure. It can escalate to that. Now, that's avoidable when patients listen to the symptoms and treat them before they have a chance to do that. All right. How do we diagnose enlarged prostate? So first is with the medical history. We look for other contributing factors. Is it a matter of avoiding and storing urine, or is it a matter of a kidney problem, and another secondary medical problem? So we don't treat everybody the same way. We first have to listen and see what the scenario looks like. Is it an overactive bladder, for example? Is this a sign of a nerve problem, like a pinched nerve higher up, that sort of stuff? So if patients have a suspicious symptom picture, a suspicious course, there are we can often start with treatment early on with, say, starting a trial of oral medication in some cases if it's safe. But if we're not sure, we have other ways to tell whether it is, if it's an unclear picture. All right. So we don't, at least I don't start automatically with studies if I don't have to. It's about listening. We're often able to start with empiric treatment with oral medications that only affect the prostate. And there's other ways to confirm that diagnosis from a clinical perspective to really start out and see what, dip our toes into treatment, see where we can get with that. But there's, of course, important roles for flow studies, ultrasounds, ways to measure both the flow of urine, make sure that it's obstructed, see if it's sort of a limited flow rate, or whether you're able to really evacuate at a normal rate, okay, based on established ranges. We might do ultrasounds often to ensure that you're emptying safely. That's one of the most important vital signs of the bladder. Is how well can you empty? And we do an ultrasound to see, what is your post-void residual urine? Are we on the verge of a bigger problem? Or do we have, what kind of freedom do we have with that? There are other studies though that we do along the way that are targeted specifically to look at the exact dimensions of the prostate. that look at the size of the prostate and of the shape of the prostate. So these two that you see over here to the right, the transrectal ultrasound and the cystoscopy, are how we tend to make those decisions. And these are two really important studies that are invasive, but that's how we can safely confirm that the prostate's enlarged anatomically, whether it's obstructing on the urine flow on the urinary tract from the inside. Okay, and these give us, the size of the prostate from a transrectal ultrasound measurement, which is the most accurate way to measure. It's even more accurate than an MRI, and we can see whether that the prostate is the source of that problem, and if there's other problems that also need to be addressed. As I mentioned, as a caveat, the cystoscopy is very important, even if we know we have a smaller prostate, because even if we were to do a rectal exam, it felt small, that doesn't mean you don't have an enlarged prostate, because again, even a small gland can be. We look inside and may see that it's pinching on the flow, it's damaging the bladder, and still a treatable source of of these problems. So very often when men are making treatment decisions, one of the most helpful tools is the cystoscopy and the prostate ultrasound, and that really tells us what we need to know to make definitive treatment decisions across the board. Okay. One thing we also do is the prostate symptom score. Okay, this is also an important tool. It's a questionnaire that's been validated, meaning it's a way to take subjective symptoms and quantify them in a way that has meaningful objective use. Okay, meaning we know that there's a strong correlation between the scales of symptoms and severity and treatment outcomes. We know that these things matter, and it's been proven in a very solid way. Okay, and it especially quantifies the degree of symptoms, and ultimately it puts it into practical measure by saying, how does this affect your quality of life? If you had to live the rest of your life the way with your urination the way it is now, how would you feel about that? It's the most simple way to ask this. And it is, every patient that comes in, when I ask these questions, all they know is that it's bothersome. And it often takes a little bit of thought, but it is very useful to kind of consider and really break down how this is affecting patients, to see whether it helps us decide, is the prostate a problem? How bad of a problem is it? Is it time to treat it? And also helps us see, as we're going along a treatment course, are we making progress with medications, or are we really stalling? And very often I'll have patients who say, well, I think I generally feel better. But when we look at their symptom score, they validate, I guess it's really not better now that I think about it. Or we'll say, I think it's changed one thing or another, but really this actually may be worsening. And so it's a questionnaire that all men fill out whenever they come into the office. It's one more intake form, but fortunately it doesn't take up too much time, but it has a lot of utility. And it's a really good way to kind of also illustrate to patients why, how these problems are kind of arising, and illustrate, when is it time to treat? Is this something that is progressing? And it's really quite useful. All right. Treatment options. Okay. So in a lot of cases, with anybody, we start with something less invasive, and that's my practice. I think that's probably the practice for most providers. Really, what the first treatment starts with is, here's term watchful waiting, but I would also add to that behavioral modification. In some cases, there are things that we can do to correct a lot of the symptoms from a non-prostate perspective, such as avoiding bladder irritants, maintaining adequate hydration, timing of hydration, avoiding fluids before bed, which may avoid additional nighttime urination problems, avoid exacerbating that, timing of diuretics, that sort of stuff. Other outside factors that may potentiate the problem. Of course, whenever men, we know that the prostate itself is becoming a problem. Often the first step is medications. Again, I'll try medications as a first line or a second line treatment, I suppose, to say, it helps answer the question is, with a prostate specific medication, it tells us that the prostate at least plays a role in your urination, and it's a treatable cause. We see whether those medications are leading to a discernible benefit with an adequate, say 1 month course of therapy. That answers the question: is the prostate is is playing a role here. And we also it also gives us a chance to say, are the medications enough to control it right now? Many times, I would say close to half the time, if not around half. I mean, they'll say it is it gets us partially there. We know we're on the right track. We didn't make anything worse. The prostate's is kind of our chief suspect right now, and basically, with an adequate trial, we can tell pretty early on what we're going to get out of those medications. The changes after those don't take too long to occur and be noticed. And usually, if patients are able to get only partial improvement after a month or two, then it tells us we're probably not going to go get a whole lot more out of that. And those patients may be interested in further therapy, or if patients are on medications for a long time and they start to lose the benefit. If they were benefiting, but clearly that response, that improvement that they saw is starting to decline, then that's also a sign that they may need further treatment as well. And that could be due to slow weakening of the bladder. Very often it's due to simply more, continued growth of the prostate that's outside of the reach of a medication. Okay. And so now as we move on to the next one, the UroLift is an example of a minimally invasive surgical treatment that really fills the gap of not only replacing the medications as an additional second line treatment according to AUA guidelines now, but it will lead to a better improvement in the symptom score, a better improvement in the flow rate than the medications can, and is a better long-term therapy. It's better at protecting the bladder by alleviating that obstruction in a rapid and less invasive way. What this avoids in men who are candidates is more invasive surgeries. All right. Now, there are a number of different surgeries that are available for men that are hospital based, whether their prostate is too large, whether it's growing in an atypical pattern, a more severe pattern where it's growing in multiple directions, other factors. Some men may benefit from those. Most often, it's men who have basically larger glands or often a misshapen one. And the problem with those is that they all require a hospital stay overnight, up to about 5 days with a catheter, and a 1 month recovery. Okay, so they're not nothing. It's a significant recovery that's necessary because of an additional bleeding risk, on top of the anesthetic risk and the and the surgical risk. Excuse me. Okay. How do we decide on that? Well, they all have their risks and limitations. The less invasive we are, the less there's a requirement for a catheter. That's a huge deal. Nobody wants a catheter. A lot of these lead to a faster recovery, a faster unobstruction than others. Medications don't may actually take more time to kick in. So I wouldn't call that a rapid relief. That often they do work a little bit more slowly than basically an extra, like a surgery or a procedure to open up. But they are definitely not as durable as something more invasive. So we also look at what is the durability of the surgery, or minimally invasive treatment. We see a similar durability of the UroLift compared to a lot of surgical procedures. It is not as durable as, say, most like a more invasive surgical procedure, and that makes sense. We don't remove the tissue with the UroLift. That's not the point. But we do. What we're looking for is a prostate that is usually of the right size and shape, to where we can get essentially a similarly significant unobstruction in a smaller gland without having to remove it. Now, whenever we do this, we want to avoid thermal energy, electrical energy, and if we can avoid removal of tissue, that there's some major advantages to that. Not just bleeding risk, not just avoiding surgical risk, but also preservation of sexual function. Okay. Most of these surgical options that we talk about beyond the UroLift all carry, this bleeding risk, and almost all of them will lead to, well, they all have some degree of ejaculatory dysfunction. Some of them it's ubiquitous, and some degree of erectile dysfunction. Okay, so the UroLift preserves all the sexual function. Okay, because it's a very well designed system, because the placement of the implant. So we'll get into this in a second. Is designed to avoid specifically the nerves that allow you to have an erection, and to avoid the muscular mechanisms and the anatomical location of how semen's emitted, to where it will not affect your ejaculatory dysfunction. Okay, and this is a real benefit. Okay, I've not had a patient after a UroLift have either. All right, so it definitely has some distinct advantages that really over medications as well, because even medications cause ejaculatory dysfunction, if not erectile dysfunction. So it's a unique advantage, second to only just not treating it. Okay, and for some guys that's just not an option. We avoid medication side effects. Again, the long recovery, and it is usually enough, similar to surgery, to get you off the medications. So that's another benefit there. All right, so let's talk a little bit more about it and what is it. So the UroLift system is an office treatment essentially. We do it. I do it. We have a surgery center that is where we use local anesthetic and some inhaled sedation, and we use a camera to go in that will basically visualize the prostate tissue, and I use that rigid camera to first compress the tissue to the side. What I then do is deploy the system, deploy basically a little anchor, almost like a little grappling hook that goes to the outside of the prostate capsule, which is sort of a fibrous sort of shell, like the skin of like an orange. Okay, it anchors that, and then it deploys an inner implant that will compress against that. It will pull towards the outer one, and what that does is it sandwiches the tissue in between, and it will compress it, and it holds the tissue open to the sides, just like the sash of a curtain. So it opens it up nicely. Most men have an average of about 4 implants placed. So we'll place 2 towards the top and 2 towards the bottom. What that does is creates a nice little open channel. So where the tissue is obstructed here on this in this first image to your left, where you see these 2 coapting, sort of kissing lobes to the side, where they touch and rub up against each other, are then restrained to the side. So you guys have a nice permanent channel that's immediately created during the procedure. All right, so you leave the procedure with immediate unobstruction. All right, this is, of course, it's hard to, since this is a PowerPoint, it's hard to really show it. This is life size, because it kind of depends on the size of your screen, I suppose. But it's about the size of a shirt tab, I would call it. So whenever you buy a piece of clothing, there's that little piece of plastic, that keeps the tag, the price tag attached to the garment. It's about the size of that. All right. So it's here compared to a dime. You can tell it's quite small. What it is it's 2 little stainless steel endpoints, and those are the 2 ends, the 2 anchors, and in the middle is a permanent suture. It's basically it's a non-absorbable type of stitch that we've been using for decades. It's an inert plastic that doesn't fall out later or erode or calcify or do anything. Okay. And basically, one of these 2 little endpoints is on the inner part where the urine flows at the end of the procedure, and the other anchors to the outside capsule of the prostate. Essentially, this is what it looks like before and after. So the left side, you see an obstructed channel, and again, as you can see, the 2 sides sort of kissing each other from the sides. And afterwards, you can see that this is immediately during the same procedure. Okay, so this is 5 minutes later after these are placed. This is probably 4 implants placed here. There are 2 up near the bladder neck where these 2 little pinches are, and there are 2 down towards the bottom. We go from open, or from closed to open right there. And it's basically allows urine to pass more immediately, and that's where we get our benefit from. Okay, after the procedure, vast majority of men do not have a catheter. I used to tell men it's 4 out of 5 don't have a catheter. I think it's more than that now. I can't give you a real figure, but essentially almost everybody I give a chance to void before they're finished, before they leave the ASC. We leave some fluid in the bladder, give you a chance to void. And in men who don't have who aren't able to, God forbid, they have the catheter in for a matter of hours. We usually leave that until about midnight, and have them remove it at home, or they remove it the next morning in the office. So it's less than a day in just about everybody. Blood in the urine is expected. That's usually worse the first day. That will often taper off over the next couple of next day or so. You may have some pelvic pain just from not from the instrumentation, maybe some pressure from the implants, but there's no restrictions afterwards in terms of activity, and there are no there's no sexual limitations. Most men want to take it easy for about 2 to 3 days, but there's no other activity restrictions afterwards, like with other surgeries or treatments. And we usually, we see some. I've had patients have improvement in their urine flow the day of. Within a week is very realistic. Most men are not totally happy with the procedure for till about a month out. And I say that because those urgency symptoms, the irritative or storage symptoms, difficulty storing the urination, that's as I mentioned, that's a reaction of the bladder to the prostate. And when we have that, it will have a few weeks before we start to see improvement there. And furthermore, it's a more durable procedure. So this will often, we'll see. There's actually new data that suggests the 5-year retreatment rate is about 13%, and that's we say 1 in 5, but I think with bigger numbers we see that improving from a recovery standpoint. It was doing, men tend to do better. Also, we have more experience with it, and it's becoming a more efficient process. And I think that's why we're seeing a more durable outcome. Insurance coverage, it's covered by Medicare, all national and commercial plans. As long as we get this, the necessary steps, we basically document what we see. Coverage is not usually a big, a rate limiting step for most patients. So in order to get started with the process, you start with the symptom survey. And that's part of intake, really. We start that even before you meet with the urologist. But you get something that you can go ahead and do on your own. Okay, it's a way that you can ask this question of to see what kind of symptoms do I actually have, and it's a great place to start for patients to really understand the disease and know where we're starting from. It's something that you can, adds a lot of food for thought, and it's definitely something that's part of an initial visit is a review of that. It's really pretty easy to get started towards treatment. As I mentioned, we don't just do the same procedure on everybody. There's initial visit. There's a lot of discussion about dissecting what are the problems that you're having, how is it affecting you, and basically ruling out other causes and not just jumping to conclusions. Not everybody with a prostate gets a UroLift. We have to see what other factors are at play here, because the last thing we want to do is is treat patients in an effective way. So after with a lot of with careful thought and everything, and careful measurement and assessment, we find that the majority of men who come in especially as these symptoms are starting, in say 40s, 50s, even some guys in their 30s, it's not uncommon, are great candidates, especially if we want to forego more invasive treatment, prevent permanent damage, and basically have a relatively rapid return to a better quality of life without having to undergo an invasive procedure. Okay. And I will take questions. All right. So how long is the surgery that day? So the procedure takes about 5 to 7 minutes. It is a pretty quick procedure. Basically, we start with sedation, some local anesthetic to the urethra, and depending on the number of implants, usually it's about 4 to 6. In most patients, we try not to have to do more than 6. If we're doing more than that, maybe the prostate may be too big to really respond anyway. But if we're putting in on 4 implants, as we do on an average duration, is about 5 to 7 minutes or so. What is the symptomatic relief rate? The symptom relief rate is usually at least 50% in terms of our improvement of our symptom score. The things that are most constant with the procedures, we have at least a 50% improvement in our flow rate and our symptom score. So um, those are pretty universal, and as long term data starts to accumulate, we see that pretty. That's the number we generally go by. So that means if we're treating it in an earlier phase, that we can definitely expect a greater degree of improvement, closer to basically back down to normal urination. But even if we're in men who have a very high symptom score, men who are, as we get somebody to come in, their symptom scores over 20, which is very severe. That we'll see half of that is a dramatic improvement too. After the procedure, do I need someone to help me get home? Yes, I generally advise that, and that's for not because you're necessarily drugged for the procedure. Okay, you're not necessarily on under general anesthesia that would require you to be, make you vulnerable or anything, but it can make you lightheaded. We're applying pressure to parts of the body that are not used to it, and it can make you very lightheaded afterwards. So we generally advise a driver afterwards. To In terms of what size can the procedure be done, the FDA has it approved up to 100 milliliter volume prostate. Okay, now most men who benefit from it, in my experience, are typically 60 milliliters or less. So the reason why is we don't want to get outside the reach of these implants. And we start getting too big. Yes, unless some guys have sort of a long, thin shape to their prostate, and it will, if there's not a lot of reach, we can sometimes reach the capsule of those. And this is then again, that's a question we answer with the prostate ultrasound. But overall, if it's getting to be that large, it's often out of the reach that we can really reliably pull that tissue aside in a meaningful way that would make it worth it. So that's my strategy in general. The upper limit for me is usually about 80 milliliters. Under that, it's realistic. We can lead to some significant improvement. Does all instrumentation go through the urethra? Yes, it does. So that's actually as painful and irritating as that sounds. Okay, it is. It's the benefit of that is we're going through a natural orifice. We're not making a cut. We're not placing stitches through fascia and closing you back like we would with other kind of surgery. And that's the good part of that is that's why we don't have restrictions afterwards. All right, since we're basically not we're going in through existing channels. We don't have to worry about that recovery process of all that healing up before you can return to normal activity. We do provide numbing medication at the tip of the penis, and you do not feel the instrument go into the penis. The part where you can feel a little bit of pressure as we go through make the angle of from the urethra up into the bladder, and there's some pressure there. But once we get that in and once we get the instrument in, you may feel a little bit of that. But honestly, with the combination of the local anesthetic, the viscous like gel lidocaine, and the sedation, patients tolerate this beautifully. Okay, so Scout's honor, it's actually really well tolerated with some sedation, and that's plenty to get through most men through it. Some patients just insist on general anesthesia. We can make that happen. It's still doable, but we have no interest in a procedure that a patient can't tolerate, because we couldn't finish it. It would get dangerous. But we do it this way because it works. So we don't have to do an additional prostate block with a transrectal ultrasound. That's bit by the wayside. We stopped doing that a long time ago, where we have to also inject lidocaine through transrectal ultrasound, or any kind of spinal or anything like that. So fortunately, we're able to what we provide for the procedure wears off that day, and we don't have to worry about additional complications by virtue of that. So you mean to tell me this whole procedure will be painless? So you may feel some pressure as it goes up. You're not going to be totally like without general anesthesia. It's not that you feel nothing, but it's tolerable. Okay. The some patients from body to body may not tolerate as well, and if you can't tolerate it, then we're not. I have no interest in torturing you. You do have some pain afterwards. You have some pelvic pain. You have burning of urination after. Those symptoms are controllable with medications. You go on with pain medications, you go on with the medication, often one called phenazopyridine or pyridium, also called azo over the counter. That takes away the burning pain, and that will get better with each successive void over time. And those are controllable symptoms. But do I promise it's pain free? No. No, no surgery or no procedure is, but it's tolerable, and it's not the same as say a surgery where you're going to have to be on high dose strong pain medications for like 3 days. Most guys have to take. If I've had plenty of patients who don't even have to take the pain medications I write for them, but I write them for everybody just in case. Is this more successful than the steam solution? I think you're probably referring to Resume, which is another minimally invasive surgical treatment for the prostate. Yes. So, in my experience, short answer is yes. Now, I'm not here to besmirch the name of another option, but I don't offer that procedure anymore. The Resume procedure. This is based on my clinical judgment, my clinical experience, having done it, as by the book a number of times. It's I do not find it a practical alternative. It can be offered to patients with different shapes of prostate than some patients who may not be a candidate for a UroLift because of the shape of their prostate may elect for that. And what that procedure is where we inject steam into the tissue with a similar anesthetic setting, and that's the really kind of the one of the big benefits and one of the reasons patients may be attracted to it because it could also avoid surgery. These other surgical options I mentioned, but it will. But the downside is that basically, the benefits have been minimal, if any. It has significant pelvic pain, significant dysuria, blood in the urine, other complications, and I just can't look. This is anecdotal to me. I can't look a patient in the eye and tell them it's going to help, and I don't offer it anymore. So it's a matter of for a given prostate would you know the UroLift is not a good candidate for guys who have say a really some patients who have a very large nodule of prostate tissue growing into the bladder, for example, things like that. And so in other cases, that's why we do these tests first is to make sure it's going to help. And we have other ways, we have other ways to other procedures or modifications of other procedures to basically treat any of those situations. So where where there's changes, we have ways to adapt to that. But yeah, so hopefully that what is that it looks like that answers your question. Okay, next question. What kind of exams or tests must be made to determine if you're a candidate? So one is we need to look at the symptom score that we talked about. And it's basically a questionnaire, the IPSS score that's available online. That's something that you can self-assess and kind of get a picture of really a good starting look and see what your symptoms are. Could it be attributable to the prostate, et cetera, interview, talk, all that kind of thing. We look at urine studies. We PSA levels, and a lot of sort of entry level stuff, just sort of routinely. But testing wise, to get it done, what we want to confirm is that one is that we have to know that you have bothersome symptoms we can attribute to it. That's absolutely necessary to get the procedure to get towards it. Two is the cystoscopy and the prostate ultrasound. All right. Now we do those procedures at the same time. We do those with we can do those with just usually local anesthetic. We can offer laughing gas or nitrous oxide for that too. But to whomever wants it. But essentially that procedure takes less than a minute. The cystoscopy takes about 20 seconds. We numb the tip of the urethra. I go in with a flexible camera that contours to the shape of the urethra and looks inside the bladder. And we look at the shape of the prostate. We look for any other factors that may be at play. We may be thrown off. It may be a stricture. There may be a bladder stone. Maybe you left your car keys in there. I don't know, just whatever's going on in there, and have a full look at what's going on from an anatomical perspective. 20 seconds, get out of there. We don't make cuts or do anything. And at the same time, we turn you onto your side. You lie in a fetal position, and I place a transrectal ultrasound probe in. through the rectum to make a quick measurement in 3 dimensions to measure the volume. Okay. We also assess the shape of that prostate. That can tell us more information and see what procedures would benefit you and what wouldn't. What are your range of options? Then we break it down. Let patients kind of know every option that's on the table, and we can answer the question about candidacy from that point, and answer your question about your candidacy for the UroLift basically right at that time. But those are, listen. The other thing is those are often, it's just good medicine at the end of the day. A lot of insurance companies want that information before they're willing to allow the procedure to go on, and pay for it, because they read the same papers we do. They know what matters. They know what figures are going to determine if the treatment outcomes will be worth it. Okay, but at the end of the day, like I said, it's just good medicine, and it's easy to misstep with, if we get too enthusiastic. Not everybody's going to benefit from everything, and we also don't want to over treat with a surgical option, when we can get an excellent benefit, a durable benefit, without having to cause permanent sexual dysfunction, and a 1 month recovery where you can't lift anything. So there's ways it can free basically give us a lot of relief, and it's just smart. So how long will the UroLift work? So there's been more data on this that's come out as basically as more studies and increasing patient numbers have gone on. So the initial data after, I think it was 10 years. Basically, it was the retreat, like the failure rate was 6% per year on the earlier studies, but the first trials, and that made some sense. And essentially, that accumulates over time. So every year there'd be an additional 6%. So after 2 years, it's 12% may need retreatment, et cetera. And 18% after 3 years, et cetera. More updated data has adjusted that, I think, for two reasons. One is we have more studies with basically a tremendously larger patient experience, and that's because this is become a very popular treatment. This is the most popular non-pharmacologic treatment for the prostate in the U.S. right now, for good reason, for the reasons that I've sort of preached on that you guys couldn't see on the slides. Again, I feel really I feel blue about that. I'm sorry about that, but we'll get to those anyway. The really now the data is about 2 to 3% per year may require some sort of require retreatment in terms of another procedure of some sort. Okay. And the 5-year data is 13.6% from what I last read at 5 years. So I'm sorry, it's 2 to 3% may require starting a medication again. The 13% is men who may require some other. 13% of men at 5 years have to have some other invasive treatment to basically retreat the prostate after the UroLift. Surgeons have more experience with it. We've made it a more effective procedure based on just experience, the learning curve, and just being able to to get that done in a more effective way. And we just have better data on it. There's really useful big numbers to go by. What's the risk of rejection of the material? Great question. I don't know if it's ever been described. It's definitely not in the clinical trials. It's not in the FDA warnings. There's no black box about this. I've never seen it, and I've never heard of anybody having an adverse reaction to the material itself. These are essentially basically that we use, it's like a surgical suture, to which patients don't have allergic reactions to surgical sutures for the same reason. And it's basically an inert metal that stays outside, basically stays within, and stays in compartments that are sort of immobile. And I've never seen an immune rejection of this. It's but a valid question nonetheless. A lot of patients ask, is there any kind of infection, super infection? Can it, like other implants, like you hear about a prosthesis somewhere, a knee prosthesis, or a neurostimulator, can those get infected later? And the answer, we don't see that either. If you think about it, one of these implants is in the urinary tract. The urinary tract is not sterile, and it still doesn't get infected. The tissue around these implants is constantly draining. It's not in a enclosed compartment locked off from blood flow or your immune system. And because it stays vascular and still drains, it just doesn't get infected. So it basically there is whatever's there around the around these implants is gland tissue that basically connects to ducts and everything, and materials basically have a way to drain out, bacteria have a way to drain out around it. And that's why we don't see it, thankfully. Let's see. If there's nothing else, thank you so much for your time. If you reach out to us, we can make these slides available. But for the sake of any kind of appointment, this QR code. If you guys haven't had the ease of using a QR code, you just basically use your smartphone camera, and you can go via this link to make an appointment. Whenever you schedule your appointment, put webinar, put the word webinar somewhere in there. We actually have slots available just for webinar patients so that you can be seen sooner than later and not have to suffer as much of a delay in making an appointment. We have certain times of the day sort of carved out for those patients. So be sure you mention that and we can get you seen even sooner. But again, thanks a lot for coming and listening to me. It's been a pleasure, and thank you so much for all the excellent questions. And I wish you all luck with it. And again, thanks for your time.